Welcome everyone to the Overlapping Claims Hospital Bundling webinar. I'm Tom Ryan with Provider Outreach and Education, and I will be your presenter. Today, I'm joined by Karen, and she's from my team. Her goal is to keep up with anything you guys put in chat, to add some links, and to kind of help you out through various pieces of information. A little bit of housekeeping for today. This information is available on the training center, and by this information we're talking about the presentation that goes with this course. You can download it now. If you miss the download today, you will be able to download it at a later time, but that later time comes after we get it added to the Encore page. Let me show you how to find this. We did have a few people who are really new and actually stated they were new to Medicare, so I don't want them to not have the presentation available if they need it. So let me just stop for a second and show you how to find it. So when you're on our website is wpsgha.com. Right in the top center, you're going to see the word Training Center. So again, it's just that top navigation bar right in the middle. When you go to the Training Center, on the body, you will find 9 different boxes. The first box in the upper left corner says Live Events. By opening this, you can then scroll down and you can download the webinar material. Again, the webinar material is simply the PowerPoint. Again, it will be removed either later today or tomorrow morning, just depending on when it gets done. But the next portion that I want to show you is just this Encore presentation. What we will do is load this recording into this Encore presentation. We will then also make the PowerPoint available under download follow-up materials. This will be the PowerPoint. Now, we do typically keep them out here for 60 to 90 days, but they do stay on Encore presentation YouTube playlist for a lot longer until the information isn't valid. So I just thought that I would show that to you because we did have a couple people who are new and weren't really sure where to go or what I was referencing with that. Okay, the last item on the housekeeping slide is just please remember that you will be offered a survey. The survey comes at the end, and what we're looking for is the good, the bad, and the ugly. What did I do well? What could I do better? And was my presentation and the resources that I've shown you, which will be website resources, other things like that, were they helpful? Good, bad, ugly. Also, along with that, we'll also be given the opportunity to grade WPS as a whole. Okay. Let's move on just to a couple of disclaimers. The information in this presentation is current, but it is only for informational purposes, educational purposes. Medicare rules and regulations will always prevail. They are available on the CMS website, but they do change often. What's nice about the bundling, the hospital bundling portion, is it hasn't changed in a while. We'll go through some of those different things as you need to know. I did take questions in advance and I have quite a few of them, so I will get through those questions first. If you took the time to submit them, I want to say thank you very much. It allows me the time to give you the most complete answer. Should time permit, questions will be taken after these questions and at the end of the program. Those will be questions that you can put into chat. If you do not have or we do not have time to do that, you will be expected to email those questions to us. Okay. Want to remind everybody that the most current information is available on the CMS website. That is important because when you're talking about changes, rules, regulations, all of that, CMS.gov is the official website. Our website, wpsgha.com, is simply guidance based on that information. So what are we doing today? Well, I want to help you determine when your claims are subject to hospital bundling. But in order to do that, we do have to start with basic definition of what hospital bundling is. For those of you that are unaware, I did take pre-submitted questions. Inside those pre-submitted questions, we had quite a few that just simply said, what is hospital bundling and how does it apply to me? Well, that's what we really need to start with, because if you don't understand the concept, you won't get the rest of the information. So we will start there. Then I'm going to go to when does it apply? That's the second portion. When does it apply to me? And so we definitely want to make sure that you have both components of it. Again, want to make sure you have that base information. If we do not get into all the details of it, there will be some ways to do that. I'm going to provide some tips and suggestions to avoid denials and overpayments. We're not going to be able to avoid them all, but hopefully I can help you a little bit. So as I said, our first section is just simply the definitions. What I will do is define for you a variety of definitions that apply to this course. When I do this, I will use these definitions in some context and try to help you understand a little bit, but they will really be more about what comes later. This section does take a while to get through, just so everyone is aware. So what is bundling? What is hospital bundling? That was actually a question that was submitted to me. What is hospital bundling? So let's go ahead and answer that. Hospital bundling is a concept that Medicare uses, which says the hospital will get a single payment for all inpatient care. The key thing here is it has to be ordered inpatient care. Now, why is that important? Because somebody asked if this bundling concept applies to observation care. And observation care can be included in the inpatient stay. However, bundling does not apply to observation care if they do not go inpatient. So if they leave observation care, it is considered an outpatient service and is subjected to different rules. So the hospital bundling concept is for inpatient care. A couple people asked also, does this apply to critical access hospitals? The answer is not to all critical access hospital services, but yes to a swing bed service, and there's a difference there. It also applies to critical access hospital services where they are performing labs or other things that would be applicable, but not necessarily the patient is inpatient in the critical access hospital. So this is what a bundling concept says. One payment for all incorporated or included services. So then we move on to overlapping. The next question is, what does Medicare consider overlapping? Well, overlapping simply means that there's another claim, whether it is from the same hospital, a different hospital, whether it's from a wholly owned entity or an outside entity, that should be part of the hospital stay. Now, the hospital stay, again, is that inpatient bill that comes in that incorporates all of that information. This is a Part A inpatient billed to the hospital. The hospital must then enter it onto their claim, and the hospital must then reimburse an outside provider. So hopefully that makes sense. Now, I will tell you, under the overlap, many times services for professionals do not fall into this. The hospital is paid for facility care, not for an evaluation and management done by a medical professional. That's a separate service. They may have to use the correct place of service, which is a different thing than actually billing the hospital. So there's a lot of different parts that go into it, but remember, the bundle is where the hospital is responsible for it, and overlap simply references that there's another service, an outside service, that needs to be billed to the hospital, so the hospital can then append that to their claim because of the inpatient bundling rules. So what is a payment window? Now, this one comes from the fact, actually, the person asked specifically, what is the 3-day payment window? So let's start off defining payment window, then we'll move into a little bit more. So this is a double explanation. First, a payment window is 2 parts. It is considered to be before they go inpatient, and it's either going to include diagnostic or related non-diagnostic services treated as inpatient services. So there are certain services that must be put into the inpatient claim. They are diagnostic or non-diagnostic services related to the inpatient service. So the payment window simply is 1 or 3 days. And it is defined by the way in which you're paid, and it is from the admission date. Okay, so let's move on to the remainder of that definition. A 3-day payment window applies when the service is paid under the inpatient perspective payment system. Not any other payment system, just the inpatient perspective payment system. And that means that certain services performed up to 3 days before the inpatient admission must be billed to the hospital and included on the inpatient charge and the inpatient claim, however you want to say that. On the other hand, there is a 1-day payment window, and that is for all other payment methodologies. One of the big questions that we got it from 5 different people, was about inpatient rehab facilities and their 3-day payment window. So when you look at this slide, does an inpatient rehab facility or unit have a 3-day payment window? The answer is no. They have a 1-day payment window. It's a shorter time frame. Why? They're not paid under the same payment methodology. Their payment methodology is different. So hopefully that makes sense to you guys when you look at that. Now, if you're not sure if the hospital is paid under the inpatient prospective payment system or one of the other prospective payment systems, which also would include a critical access hospital, they're paid under a completely different payment system. And again, because it is an inpatient and a critical access hospital and their payment methodology is so different, even a 3-day, 1-day does not apply to them. You may have to ask, what are you considered? You may know, like for instance, a critical access hospital, you may say, oh, hold on, yep, got that. That's a small community hospital. That's how this one is paid. Here's the criteria that need to be met. If you don't know, you need to ask. Okay, make sure that you're aware of it because the name doesn't always reflect how they're paid. Another component to this is wholly owned or operated. Hospitals is the sole owner or operator of an entity. What does that mean? The hospital is exclusively responsible for implementing policies, facility policies. They don't have to have administrative control. That's not part of it, but they do have to implement the facility policies. Now, wholly owned, as it sounds like, I'm the sole owner of this particular entity, this particular long-term care, whatever it is. That's wholly owned. Wholly operated, they are not the owner, but they have the governing control for implementing the policies. Hopefully that makes sense. I was specifically asked if there are excluded providers, and you've already heard me talk about one, and it's critical access hospitals. Other types of things that are excluded. One, maintenance renal dialysis services are excluded. They're not necessarily going to be included because of the bundling, the type of service that it is. If there's a skilled nursing facility service. So one of the questions that came in was, what happens when there's a skilled nursing facility inpatient claim and a hospital inpatient claim at the same time? Medicare systems cannot allow this. So one of them will be rejected. One of them will not even process because there's already an inpatient claim. How it works is first in, first out. That means that we will process the one that came in first and the first one to go out. The second one will reject. So I'm not really sure what's going on with that situation, other than maybe a discharge wasn't billed and you got around to billing your claim before the discharge was billed, and the system has to have that as well. Home health agencies are exempt. Hospices are exempt. We did talk about critical access hospitals, and again, when they are the admitting hospital, they are exempt, but not for swing beds. Also not when the critical access hospital is performing a diagnostic or something else that would be included, but they are not, the patient is not admitted into their facility. Rural health clinics are exempt, and so are federally qualified health centers. A lot of these exemptions are the way in which these claims and this information is paid. So it really is about making sure that you know exactly what you're doing here. Okay. So the next slide is to say, okay, we're going to summarize all these definitions and we're going to put some questions in to get through to make sure. So let's start with number one, regarding combining acute observation with an inpatient rehab claim. I'm not sure if you're at an acute observation stay or if you're with the inpatient rehab claim, they're paid differently. So are you trying to combine them into one? What are we trying to do with this? And I will tell you that when we look at that, if that's what you're doing, there is codes that can be done. The next one, when observation hours are within 72 hours of the IRF, inpatient rehab facility admit, does the claim need to be combined? Let's stop for a second right here. First, we talked about IRF, inpatient rehab facilities. They are not a 3-day payment window. They are a 1-day payment window. So can you tell me if that IRF is considered an independent? Is it considered part of a hospital? It's just a separate unit. And how is it being paid when you bill it? So there's a variety of different factors. Also, observation hours are combined when it's 1 day before, if the IRF is independent. If it's not, and again, if it's acute care hospital, then it could be up to 72 hours. And yes, they are combined because they are related. If they are completely unrelated, then they are not combined. Someone did ask me that question, and they have a situation where the patient was in observation following some surgical care because they reacted to a anesthetic. During the time that they were in observation, however, they had a heart attack. So they were admitted inpatient due to the heart attack, not due to the reaction. The reaction was not a contributing factor to the heart attack, according to what the question was given. So we would look at things a little differently there because then they're not related. Hopefully I answered all of those questions kind of together in one lump sum. How do you process an inpatient observation claim with surgical procedures and admissions to an IRF 2 days later? Okay, so if it is an IRF, we're going to look at 1-day bundling first. I don't know, when you're saying observation claim, I'm assuming you mean it's not inpatient, it is observation. Remember, inpatient is a different type and observation is a different type of claim. Even though they're quote unquote in a hospital for observation, this is considered an outpatient service. With surgical procedures, I'm not sure when the surgical procedures were done, so I don't have a lot to offer on that. The reason that I say that is, let's say that they were done 2 days prior, then those surgical procedures and some of that observation care would be separately billable, other things would not, because it is an outpatient service. And so then when you hit the actual IRF inpatient admission, that may be the day before. So lots of things going on with that one without a clear and concise answer. I'm going to give you a couple of resources that might help you. One of these resources is from the Internet Only Manual. It's the actual information given to everyone about the Medicare Claims Processing Manual for Inpatient Hospital Billing. I do recommend checking out section 40.3. That is the portion that talks about what we're talking about when we talk about the 3-day, 1-day payment window. Now, again, the 3-day, 1-day payment window is not all information about hospital bundling. It's just the questions that we had for this portion. The second one I gave you is the original notice from CMS putting the 3-day, 1-day payment window and the outpatient services treated as inpatient into play. It's got some great information. It does have information that is still current and a lot of good stuff within it. In terms of other hospital type bundling questions, yes, an ambulance service is billed to the hospital when the patient is inpatient. No, the hospital service cannot independently bill that ambulance service. That means that when they bill that ambulance transport, they incorporate the cost into whatever the transport was to. So if it was an MRI, if it was something like that, they actually have to do that because a revenue code 540, which is the transport code, is not able to be on an inpatient claim. And we'll talk more about that as we get into it a little bit further. Which means that we're done with those pre-submitted questions and we're going to keep going. Okay, so what's next? Next, we're going to just explain a little bit about the concepts when the bundling works and how all the billing works and the basic things like that. So we're going to look a little bit more at some of these basic pieces of information. So when we look at bundling, billing providers must determine who to bill. That is part of the bundling concept. Are you supposed to bill the hospital? Are you supposed to bill Medicare? And for which services should you be able to bill? Now, if you bill a service and then we get an inpatient claim and that service should have been billed to the hospital, whether it's part of the 3-day, 1-day payment window beforehand or during the actual hospital stay, we will start an overpayment. We will start an overpayment. This is an unsolicited response from the common working file. The common working file is the communication hubs between the claims processing systems. It also has eligibility information, primary payer information. All of that is stored in the common working file. But what happens is in the Part A processing system, which is called FIS, and it processes UB04 and 837I claims. Once an inpatient type of bill is submitted, it will override outpatient types of bills or services in the MCS, the multi-carrier system, which were billed on the 1500 or 837P that should be included. Why do we say should be included? Because remember, I said some of the physician services, like the evaluation and management services, shouldn't be included. Now, some of the labs that they do will be, but the physician service directly themselves will not be. So it really just depends. And the common working file actually will instruct the Medicare system to create an accounts receivable and send you a request, completely automated. We don't look at those. We don't have anything to do with it. The system talks to the system, and the other system creates everything and does everything. We don't need to worry about that. So that's why sometimes you get those and you're like, wait, this doesn't make sense. It should have been this, or we don't have any control over that until you appeal an overpayment, and we'll talk more about that appeals in just a little while. Okay. So I was asked specifically what types of services would be included in this bundling. So all inpatient items and non-physician services. Key things there is non-physician services. Inpatient items would be anything given during the inpatient stay, such as room and board, some of those types of things. One thing to note, if it is an excluded Medicare service, meaning Medicare never pays for it, then no, it's not going to be included in this. So an example of that would be like a comfort item, like a fan. It's just not paid for. So therefore it's not included in the bundle because the patient's actually responsible for it because Medicare never considers it. Also, lab services and radiology services are included. One thing to note when we look at lab and radiology is if there's a professional and a technical component, the professional component or reading is typically not included. It is considered a separate service. Total parental nutrition, pacemakers, and other prosthetics and transportations for an included service. Now, if you notice, transport for an included service is just a bit lighter, and that's because that was the one that I had the question on that I said, hey, it really does depend a lot on what's going on with that transport. Was it during the admission? What else do we have to do with it? And there's a lot more that goes into that. We will talk a little bit more about that. So we were also asked, are there certain things that are just not included in this bundle? And the answer is yeah, pneumococcal vaccines not included. Ambulance services that are separately billable. What does that mean? It's not related to the inpatient care and you're not transporting for a test or something else that is included. So for instance, an ambulance service being transported from an independent ER to the hospital. Now, we're not saying it's not when I say independent, it doesn't mean that it's one of the freestanding ERs. It just simply means it's not financially tied to. So you're actually transporting to the closest facility, but that's not the same facility as the one that you left. So there's no wholly owned or operated. Those would be independent and separately billable. Part B inpatient services. What is a Part B inpatient service? It's something that is not covered under the Part A benefit, but it would be covered under the Part B benefit. Or there's no more Part A benefit allowed, which means 90 days has lapsed for inpatient care, which is all the benefit is, and the patient did not choose their lifetime reserve days, which is an additional 60 days. So hopefully all of that makes sense. I already talked a lot about observation. Observation is not included. Not included. Observation care is considered outpatient care. That's just a different payment method. And then anything that is the alternate payment method models. So there's a couple of those out there for you to look at. One thing to note is that if a hospital bills a leave of absence or interrupted stay, that's not included during that time. The hospital will not be able to bill for those days. Well, I shouldn't say they don't bill for them. They include those days on their inpatient, but they tell us that, hey, don't pay us for them. Don't count these towards the patient days because they're not here. And during that time, we do not then include those into this bundling concept because the hospital is not being paid for that. Doesn't mean a patient can't receive care. It just means, hey, the hospital didn't bill for these days. One of the things that actually occurred in one of the questions that I got is, how do we know if the hospital, or I'm sorry, if the hospital billed a leave of absence? Really, the only way to know that is to ask. But in this situation, from the question that was submitted, it sounds like you billed your claim before the hospital billed their claim. So what happened is you did a service, you recognized the patient was on a leave of absence, but hospitals don't bill on a basis like the Part B services would be billed or the outpatient services would be billed. Hospitals bill on a 30-day increment, which would include the leave of absence. So the 30 days passes, the patient remains inpatient, which is what this was. However, during that submission of a claim, there was a period of time where they were not at the hospital. And that was a period of midnights. And what happened during that time was the patient then had to go out and went to the doctor's office and had to get some diagnostic tests done. Again, that's not part of the inpatient bundle because the hospital wasn't paid for it. But it looked like it was because we hadn't got the claim and we were still showing they were fully inpatient. So there again is one of those situations where the billing type directly affects what happens. And so if we had waited, because again, it can take 30 or 60 days to get that hospital claim billed, and then it has to process before posting to the common working file. So if it hits for medical review, if it stops for any reason, if it returns to the provider for any reason, it won't post to the common working file. And then once it posts to the common working file, in this case, it would have allowed that claim. However, because that claim was denied, now the provider has to rebill it. So lots going on there. Hopefully I explained that well enough to answer your question. Okay. Oops, sorry, I forgot to advance to the question slides with that one. So that's my fault. What else do we have? What is the facility that they were inpatient at the time in Medicare show the patient is inpatient? Okay, I'm not really sure how this one based on the wording, but what I'm guessing is that you mean, um, why doesn't Medicare show which facility they're in? And this is part of that information that's communicated back and forth with the processing systems. And if it's not communicated from the claims processing system into the eligibility files, which is where we actually display the days that they would have deductible, inpatient deductible, and we have all of that applied, our systems can't display that for you. If that wasn't the question, it could also mean, again, they are not inpatient anymore, but our system is still saying they are. That happens when the inpatient facility does not properly bill a discharge. And yes, this can happen frequently. We actually have had to have people file appeals to show, hey, this person really was outpatient at this time, even though you're showing an inpatient claim, and we've had to go back to those facilities and be like, hey, you need to correct your claim. It's not right. So it's just a variety of things that can happen, and I'm not sure what you were referencing here. Okay. Someone did ask if does the overlapping services pertain to a freestanding psychiatric hospital that sends their patients to a medical hospital ER. There's a couple of concepts that you need to keep in mind. First, it's only for a 1 day. Before that, if you're sending them out, are you billing a leave of absence or are you discharging from the psychiatric hospital? What's going on with that? If they return, now the same day, Medicare may say, wait, that should not have been a discharge. That should not have been anything. We're just going to make it all one claim. The concept could apply. So no easy answer on that one, but let's say you send them out, you bill them as a discharge or a leave of absence. They say they're maybe for a day or two, in the ER. And by the way, 2 days isn't necessarily 48 hours. 2 days is simply, hey, I got there on Wednesday at 10:59 p.m. and I left on Thursday at 3 a.m. In the Medicare world, that overnight, that quote unquote 2 days, is what we're looking for with a leave of absence or interrupted stay. So just so everyone is aware of it, I want to make people well aware of that. So it really does depend on a lot of principles and concepts going into that one. All right, I'm gonna keep going here. Oh, actually, I'm gonna check with Karen. Do we have any questions?
Tom, we haven't had any questions come through in the chat.
Okay. Well, I'm not sure if my chat is working. I tried to make sure it was on and everything was set up correctly. And according to all the instructions from WebEx, it works fine, except sometimes it isn't allowing people to submit. What we'll do now is we'll keep rolling through and we're going to hit some tips. So one of the basic things that we do start with, condition code 51, attests it's an unrelated service at the admission. That was the example that I gave where the patient actually had a heart attack, and that's what the inpatient admission was for. But all the other services, which could be the observation care and all that stuff, when those claims are billed, we do want to use a condition code 51. PD modifier allows the wholly owned or operated physician practice other than a Part B entity. This identifies the procedure code is subject to the 3-day or 1-day payment window. So what that means is this is a physician practice that is owned or operated under the hospital that they're going to be admitted to. So therefore, this would be part of that bundle and would be included on that hospital stay. So you want to make sure you're using the correct piece of information, and it really does depend on how you go. So let's see, a little bit of question that we did get, and I'm just reading through how the question with the answer together because I forgot it. Okay, so is the PD used the same as the 3-day, 1-day calculation? And the answer is yes. Again, inpatient perspective payment system, 3 days. Everything else, 1 day. Not used if this concept does not, 3-day, 1-day does not apply. So critical access hospital, you wouldn't use this because your payment methodology doesn't allow for this. The admitting hospital is responsible for notifying the other entities if the patient was admitted inpatient. I want you to take that was admitted inpatient because inpatient is when this applies, not observation. Okay. This one becomes quite interesting, and this is ambulance transports. So let's start with some basic things with ambulance transport. First, an ambulance transport must be medically necessary for Medicare to consider it. That means if there's no wheelchair van or if something's not available and that's why you're using the ambulance, that's not a payable transport. Okay, so start there. Also, remember I talked about when we do the ambulance transport for a hospital bundling, we need to look at the service at the ends and to determine if that would be something that would be bundled as well, because that's how the ambulance transport becomes part of the payment. That service is billed, the cost for the transport to get them to and from that service is part of that service. Therefore, it's billed with that service when it comes into Medicare. Okay, so it gets a little bit different. If the transport is to a facility for an admission or after discharge, then they are separately billable. Lots going on with ambulance services, and hopefully we got those questions answered. We have a few more coming up a little bit later. One of the big tips we actually do have for you is please don't forget to discharge that patient. Bill the claim appropriately to let us know it's a discharge and not an interim claim. A type of bill would be where you'd want to put that. Why is this important? Because it actually affects the future processing of your claims and other providers' claims. So think about it. You discharge the patient for 40 days, then they try to, but you don't bill it properly. You don't bill it as a discharge. You send in a claim. We're looking for a continuation claim. We're looking for a series claim, not a new admission claim. It actually means you may not get as much money, and it does affect how you bill. So please make sure that the discharge is done. Now, can it affect other people? Sure. During that time frame, wouldn't all of those services not be subject to the bundling? Well, they would be separately billable, but right now they all show that they should be wrapped into the hospital claim because the hospital didn't discharge the patient correctly. So please make sure you do that correctly. One of the tools I was very specifically asked about was the SecureNet Access portal and what information would be available on this. So the SecureNet Access portal is available on our website. I'm going to stop and go out there. I want you to just, check this slide. It'll help you understand a little bit about what you're looking for. So we're going to look at the eligibility, the summary, and the deductible days in the system. All right, we'll talk a little bit about the limitation. So again, the SecureNet Access portal is something that you have to log into, which means you have to have your own username and password. It is available on the website on every page. So right now you can say I'm on the Encore presentation page, but if I go back to the beginning, it's there for you. Once you log in, this will go away, but you can still get to it. Here's what I want you to know. The portal user manual contains the instructions for using the portal. Step-by-step directions for using the SecureNet Access portal. What we're actually going to do is, one, if you're looking up claim status, yes, that is here. I'm just going to scroll down and you can see patient has claims. It has a bunch of different stuff, but it also has eligibility. This is going to be your first starting point. And what you're going to look for in eligibility is how many days are used. So let's go ahead and just do an eligibility check, and I'm just going to scroll through this. You would have to enter eligibility, and yes, you have to enter the required information. This is a CMS requirement. I don't know how else to answer that from the question that was sent in. Eligibility is selected. Then you've got a summary screen, and the summary screen talks about, hey, what's available to that patient for the entire year. But then you've got a deductible screen, and I want you to move to the Part A deductible screen. And inside the deductible, it talks about what's going on with that deductible for the year. So what's remaining, what's the hospital spell of illness days, what's the hospital copayment days that are remaining? Because remember, once the patient enters into a hospital, they have a certain time period during a benefit period. It's 90 days, and that's what all of this stuff is helping us understand. Same thing with a skilled nursing facility. Okay, so if the patient has this in there and they have this spell of illness listed, this is where you'd want to check to see if they're currently in a hospital stay. If not, then an inpatient discharge and admit was billed and it closed it, and that's what you want to make sure of. Scroll back up here. We're going to go back to the portal user manual. If you need to check the status of your claim, or you need to make sure that something is working correctly, go ahead and check your claim status. Scroll down, you'll be able to see what's going on with the claim. Again, you have to enter the information, do your search. And I know I'm going through this very fast, but it'll tell you why something was denied or why it happened. Now, if you understand, hey, it was denied, now it's time to call customer service and say, I know it's denied. However, this doesn't make sense. This denial is not correct. It doesn't make sense, something like that. That's when customer service can be involved, but please don't call them saying, hey, by the way, all right? So just so that you have that information available to you, but I wanted everyone to be a little bit more aware of all of that. Karen, you do a lot of the portal education. Is there anything else that you can think of that I should be showing them with the portal?
No, I think you really hit, especially with on the summary screen and on the Part A deductible. That really does provide a lot of information that I think would be helpful with billing.
Okay, perfect. Thank you. Again, before I left, because our next section is more questions. Oh, by the way, the system limitation and what is limited here. Remember, the portal also works off the common working file. It is done through the HIPAA eligibility transaction, or HETS. This is a standard transaction. It's 270, 271. If the information is not updated in the claims processing system, it will not transfer to the common working file. Therefore, it does not transfer to the portal. Can't happen. We don't have it there. So that's really the limitation we're talking about. Hopefully that all makes sense to everybody. So again, what is it dependent on? What's in the processing system, both again, the UB04 837I processing system called FIS and the CMS 1500 837P processing system called MCS, or multi-carrier system. So hopefully, you're aware when we say that, what we're really looking at. All right, let's move on. I'm going to do a little bit of wrap up, but I'm going to do some question and answers. Again, this is where we're going to hit up any question that was submitted that I don't think I've answered yet. Okay. What are the best practices for identifying and resolving overlapping claims denials between inpatient hospitals and SNFs, especially when both providers believe their services are separately billable? Well, if you have 2 inpatient stays, there's something that isn't going to work correctly. Did y'all catch that? Something isn't going to work correctly. You cannot be inpatient at 2 facilities. You can be on a leave of absence or an interrupted stay from one, but that has to be billed correctly. So what you first have to do is determine, where were they admitted? Where were they inpatient at that time? Okay. Now remember, the Medicare system will take a first come, first serve. So if the SNF bills there saying, hey, they were here and they were inpatient here, but does not bill for a leave of absence, even though they went to the hospital, or doesn't bill for an interrupted stay, even though they went for the hospital, we're not going to be able to process that. So when I really do recommend that, it starts back at the basic billing. Is that stuff done correctly? I also always recommend, and that's why one of the reasons we showed you that eligibility screen and we showed you the second Part A deductible screen, you can take a look at how many days are remaining in the spell of illness. That should tell you whether or not there's something overlapping. Because just remember, with an overlap, if a leave of absence or interrupted stay is billed, it's not going to stop a spell of illness. It's just going to give us a little bit of a break in the middle. So it'll show on both, and that's okay. As a matter of fact, the Medicare system may even process both of them in that case. I'm not really sure what else to say on that one, because again, you get one inpatient stay. You can't be inpatient in a SNF and a hospital at the same time. And so really they have to go back through and work together to determine, how are they inpatient at both? What's going on? What is happening here? Hey, by the way, yes, the SNF should be billing a leave of absence at this time frame because they were at our facility over a midnight stay. That's a leave of absence from the SNF. So I don't really have any better advice than that. So hopefully that helps you. Just confirming which services are bundled for a provider on the day of an office visit with the same day direct admission to the hospital. For example, a patient is seen for pain management in the visit of the office where he has a urine drug test for long-term care of use of opioids. And then he has a heart attack. And so we send him to the EMT transport to the hospital for admission and treatment. So I do want to let you know, this is the exact situation where you would need to bill the modifier. We talked about it, it's PD. That modifier indicates, I'm sorry, do not bill the modifier PD, sorry. That modifier would indicate that they are related and you do not want them related. If you're both billing on I can't remember the condition code, hold on one second. I do have to scroll up for just a second because I forgot the condition code. If you're both billing on the same claim form, you will want to bill a condition code 51. Okay? So we want to make sure we get it billed correctly. Getting back down to that question slide again. So when we're looking at that one, remember it has to be a separately billable visit. I will tell you that many times the office visit shouldn't bundle. It shouldn't even be a consideration. It's not wholly owned or operated. It's going to have professional services and other things like that within it. But if it does, you may need to do an appeal. And we're going to talk more about that because the next question is, how does the appeal process work? Okay, well, let's keep it super generic here. And I will get a little bit into it, but the appeals process is the same as any other claims appeal. So first, if you have appeal rights, you're welcome to follow them. That would be an MA01 on your remit notice, or that's going to indicate you have that first level of appeal right. I will recommend a resource for you, and I don't have a link for this. I'll get it in just a moment as I actually pull it up. I'm going to recommend that you go to the CMS website, Training and Education, Medicare Learning Network. And if you want to learn more about just the general appeals process, you're going to go to resources and training and then the publication and multimedia. Here, what I like to do is just type the word appeals, and you can see we have a booklet on appeals. It's going to give you your general information. What I like about this booklet is that it breaks it out by the 5 different levels. So scroll on just for a second here. You can see there are 5 levels. If I select the first level, it'll take me out to the CMS website. I don't have to hunt and search for things. It just automatically moves me around, which is awesome. All right. Let's go back to the booklet for a moment. If we scroll down, again, I'm not going to select that first level. I'm going to scroll by it. It will also look at the appointment of representatives, 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 the appointment of representatives But then it gets into each level, how long you have to file the appeal, how long we have to complete the appeal, how long, all of those different things. So this is just a really good starting point. Again, I wasn't really sure what you were looking for exactly with the question, because the question was how to appeal. Well, this is how you do that. But please make sure that you do have appeal rights and that you're following through on the information. Along with that, I was asked, is it better to use an appeal form from WPS? My answer to you is, yeah, that's going to be the best way to get us all the information that's needed. Go back to WPSGHA.com, select your line of business. J5 Part A equals Iowa, Kansas, Missouri, Nebraska, and national providers. That bill on a UB04 or 837I, you are Part A, J5. That's the line of business. J5 Part B, you bill in a 1500 or an 837P, and you are in Iowa, Kansas, Missouri, Nebraska. Indiana and Michigan, you are J8, J8. UB04, 837I, CMS 1500, 837P, so the B routes remain the same. Once you select your line of business, go ahead and use the topic center and go to the word appeals. Once you get into the appeals area, you can scroll down and look down here, but you're going to get a lot of different things that might help you. Here's what you're looking for, and this is what I think the person was missing. This forms section right here, right on the top. This is where you can find our appeals forms. Now, what's nice about our appeals form is just that, one, it's a redetermination request. Yep, that's the first level of appeal. But what's nice about it is if you do choose to download it, you can fill it out and save it. But it also has, is this related to an overpayment? And so that's just important for us to know. In this case, it may not be related to an overpayment, but it also could be. Remember, we talked about those unsolicited responses, and we're saying, oh man, yeah, it's related to an overpayment, except it's none of these, but it's still related to an overpayment, okay? Then just tell us, does this, yep, it does involve an overpayment. What type of overpayment? Give us some basic information. So hopefully that helps you when you're looking at that form as well. I'm not really sure where to go from there on the appeal process because it's a lot of information and there was a lot given on that. So one of the next questions is, our facility uses recurring accounts. Is there a way to prevent overlapping on a UBO full UB claim since they are on a monthly basis? We encounter this issue all the time. First, I'm going to put in an assumption here. I'm going to assume that a recurring account means that it's a set time frame in which you bill those out, which is what creates some of the overlap and what creates some of that information. One of the things that we always recommend is that you don't do these on a 30-day increment. Remember, Medicare has 30 days to process any clean claim. That's a claim that does not go through medical review. It does not have to stop in the system at all. While we can process electronic claims in 14 days and paper in 29, we have 30 days. So if you're setting a reoccurring lapse and say, okay, on the first of every month, especially the first day of March, you have not even allowed 30 days. So that's automatically going to create that, or could potentially create that. On the other hand, what we do recommend is when you're looking at the recurring accounts, you look at whether or not Medicare has, one, applied it to deductible, two, process the claim. Is it in a return to provider status? What is going on with it before you just automatically set these reoccurring accounts? This is the best way to do it. If a reoccurring account continues, and we can look at it from an abusive standpoint because you're costing Medicare money to build edits to stop from doing that. So it can be considered part of the abuse. It's not intentional, it's just, it is what it is. It's costing Medicare money. So if you use a reoccurring account and you are getting a lot of duplicates, there's probably a reason for it. There's something going on. Was your claim really allowing the full time frame, even if we don't do development? Because I will tell you, once we do development, your timeframes increase a lot. And if you have a development that occurred, that can cause other things to happen. If you have a return to provider, our 30 days increases. So recurring just may not be your best option. If a patient uses the hospital days, does the bundling apply? I'm going to assume you're talking about the 90 inpatient days with the potential of 60 lifetime reserve days. And the answer is yeah, if the patient elects to use the lifetime reserve days or uses any patient of the 90 inpatient days, then hospital bundling does apply. Please keep in mind, you do not use those for a leave of absence or an interrupted stay. You're not using any part of that 90 or any part of that 60 during that time frame. Therefore, hospital bundling does not apply. The next one was simply ER to observation, then observation to inpatient. I'm going to assume that this is paid under the inpatient prospective payment system. Not sure, but yes, the 3-day would apply here. Very much could apply, especially if it's all owned by the same hospital. I'm not sure the time frame and the facility type, so let's say that it wasn't, they weren't admitted inpatient to an acute care hospital being paid under the inpatient prospective payment system. It's one of the other payment methodologies. Then it would be a 1-day that would apply. So the observation portions of that might apply, but not like the diagnostic tests and things like that, but not the actual observation care itself. This one is really hard. I'm not really sure what you're looking for. So hopefully I gave you the best answer I could there. Next question. Is an ambulance transport that occurs during the inpatient stay to another facility for a service and back, again, ever separately payable? Our facility also has ambulance services, and there are many instances where the patient has to go to another facility for a service that we cannot provide and then come back on the same day. No. As described earlier, these are always subject to the hospital billing. Even if they're going for another service, maybe your MRI machine is broken, maybe you have something like that happening, maybe you just simply don't have one. This is part of the inpatient stay. If the service at the end is billed to you, then so is the ambulance. You do not, however, get to put the revenue code for an ambulance on the claim. This is an inpatient stay. What you do is incorporate that cost into the other service, but you're still responsible for paying for that ambulance transport. Next question, do different specialties under internal medicine get bundled? When all specialties are part of the same group, specifically hospitalist, geriatric, infectious disease, endocrine, internal med, are these specialty services which can be billed separately? So my answer is, as far as I can tell based on the information given, yes. These would be professional services, and professional services can be billed separately. But again, there was, some specific criteria given. If it's wholly owned and operated by, then no. So I'm not, you might need to append the PD to indicate that it is a wholly owned and operated situation. If that happens, this one's a little bit trickier for me because again, can you help me understand exactly what you're looking for? But I will let you know that for the most part, when these specialists are done separately, they will be billable separately on the 1500 claim form. Hospitalists may be the exception. Hospitals always work in the hospital. They're usually billed by the hospital. There's just a variety of factors. Now, some of their services are also billed in a 1500 claim form, so it gets to be a bit tricky there, but because they're owned by a practice that is wholly owned or operated, they may actually be bundled, which you would want to then use the appropriate modifier. Okay. The next question is how to bill a swing bed that actually occurs over 2 different years. This is not something that we can answer during this. This is not related to bundling. This is how to bill this, which is actually covered because it is a swing bed. It's actually covered in a series of courses on billing swing beds. I'm going to put a series of links. These links are encore presentations that one of my coworkers, Aline Ziegler, has done, and they actually cover all the portions of billing basics and swing beds. Not basic enough for this type of course, or too specific for this type of course. So, okay. Last question that we have. Why are EMS claims denied for services included in a payment for other services when the patient transported between 2 distinct and separate hospitals for a higher level of care? Denial is indicating the EMS transport is included in the inpatient stay. Okay, this one is very hard to answer. And the reason that it's very hard to answer is there are a variety of reasons this can happen, including the fact that the original hospital did not bill the discharge properly. Therefore, we're not seeing it as a separate and distinct service during a time when they were not inpatient. Second, if they're wholly owned and operated. So I understand that you see them as separate services or you see them as separate hospitals, but does one control the other? Are they controlled by the same body or the same home office? If they are, then this concept does apply, and actually those may be billed as one inpatient claim. It just depends. There's a variety of other scenarios that go into this. That's why when you look at something like this, you do need to contact customer service. And what you need is the individual claim number. What you do not want to ask is my claim denied? Or my claim denied? Yeah, you can check that on the IVR. On the other hand, what you could ask is, I see this denial. However, it doesn't make sense as I'm showing these are wholly owned entities, or I'm sorry, these are separately owned entities and operated separately. Therefore, this concept, this bundling concept shouldn't apply. Now what they're going to answer is they're going to have to look a little bit further into it. Someone asked if there's another option they don't want to call customer service. There's always the option to write to us, whether that is through the secure portal, the secure message in the portal, or whether that is a written inquiry. Include the internal control number of the claim, the document control number, whatever you want to call that. This will go to a different person than does the general inquiries coming in on the phone. This goes to a higher level person and it may be able to help you more. So just kind of keep all of that in mind. Hopefully that is good information for you. One thing before I get into the certificate of achievement, I'm not going to ask Karen if we have any more questions because we're so close to time here, but I do want to let you know customer service is changing our process, and you've heard me refer to customer service a few different times. What they're doing is looking at one NPI, one PTAN as a combination, and then if you have more, so it's the same NPI but different PTANs, you will need to call back in. This is to increase efficiencies. If you'd like to learn more about that, do take a look at our website. Look in the news section, which is right down here. I like to do all news, and then I just kind of scroll through, and I'm looking for an article called Customer Service Changes. Process change for customer service. It just explains what you need and all that different great information, but I want to make you aware this is effective as of August 4th. Okay. To let you know what will happen from this point forward, we will send you an email next. Now, we don't personally send this. This is a system-generated email. Inside that email, look to the bottom of the email, and it will have a certificate. That certificate has contact hours. Governing bodies may choose to take those contact hours as CEUs. We do not control that, and we do not control whether or not they will. It also has a link on the top. It says your opinion matters and provide feedback. This is a link to our survey. It's one of the many ways you can get to it. And I'm going to talk more about the survey in just a few moments. I know I did not get to all the questions that we had, so if you do have a further out question or you want me to take a look at something further, you do need to email us. Please include in the topic line hospital bundling so that I know it should come to me. If you joined us via phone, please include hospital bundling in the subject in the topic line, in the subject line with your phone number and say certificate. I need a certificate. You're not going to get an email if you only dialed in via phone. Remember that if it's something where you have an internal control number, if you have a document number, if you have something like that, that has to go to customer service. We're not allowed to answer those types of questions. Okay. Moving along, please take our survey. I know some people hear survey and they instantly cringe and go, oh, I don't want to do that. The survey is important to us. And again, I do want to know what I did well, what I could have done better. Did you like the websites that I showed you, the PowerPoint presentation? What did you like? What didn't you like? What would you better? Also, you'll be given the opportunity to grade WPS as a whole, and you'll be given the opportunity to provide us with additional education items that you would like. They don't have to be related to anything to do with today's topic, so keep that in mind. Education items, we just want to hear what you want. I was asked, how can you link to the survey? Karen put a link in the chat. You can take it right now. Again, we showed you the email already. You'll get a link there. You will also get a closeout box, which is this bottom picture, and it says external site, gives you a destination site. This is us asking you to take the survey. This is WebEx way of saying, hey, your host wants you to go somewhere. Here's how they do that. If you take this as an encore presentation, you'll be given a picture that looks like online survey. You can select this, it will open your chat, and there'll be a link there for you to take the survey in the encore as well. So lots of different ways to give us that feedback. Want to let you know that we do hear you, we do listen, we do make changes based on the surveys. A couple of ones that we have added are chapters to YouTube and the training indicators. You may see these coming out now. We're also looking at how can we change our website, the training center, to better fit your needs. So if you have suggestions for that, incorporate that into the survey. So thanks everybody for attending. I hope that you got some good information out of this. Remember to complete the survey. Give us your topics, whether it's related or unrelated to hospital bundling. On behalf of Karen, myself, and all of Provider Outreach and Education, thanks for participating today. We do look forward to your survey comments and for you attending in future education. You may now disconnect.